Hello and welcome to this week's episode of Medisodes. Today we're going to be talking about amputation and prosthetics. So many of you have probably watched the Paralympics, where many of the athletes have either a missing arm, missing leg, or they might have a missing foot or other sort of missing limb, and most probably they've had an amputation. Given the Winter Paralympics is happening this week, we thought it'd be a good time to educate our audience about what amputation is, um, why we have to do amputation, and what prosthetics are available and the problems that can come with amputation. So let's start with, why do we need to do amputation? So amputation is the surgical removal of a part of the body, and it's usually one of the limbs, so either the hands, the feet, the leg, or the arm. And obviously, this is quite a drastic surgery to carry out. I mean, removing a body part. But unfortunately, it does have to happen in certain cases. Firstly, due to trauma. So about 45% of amputations happen because of trauma-related reasons. For example, if you're in a car accident or you have an industrial accident at work, perhaps in places such as construction sites, can be quite dangerous, and also in combat. So people in the army can sometimes need amputations if they've been injured in combat. And for example, your limb could just be cut off or torn away in a severe accident. For example, a bomb going off or a gunshot or something like that. Or they could be the limb could be badly damaged. For example, be crushed, or if there's severe burns to that limbs, that means it can't be saved. You might have to do an amputation. Also, if the blood flow is cut off to the limb for an extended time, that can lead to tissue death, and that can also be, for example, during frostbite. If the blood flow is cut off, then the tissue dies, and therefore you might need an amputation because of that. But the vast majority of amputations are due to surgical reasons, and most commonly vascular diseases. You might have heard of diabetic foot. So when you have diabetes, if you don't maintain proper blood glucose control, you might get something called peripheral neuropathy, and that's basically where the nerves at the periphery of your body, so your fingers and your toes, start to basically get damaged because of your poor glucose control. Your glucose is too high, and that can lead to damage, and over time that can lead to something called peripheral arterial disease. That's basically the narrowing of the blood vessels supplying blood to the legs, and that means the restriction in the blood flow can lead to tissue death at the extremities. For example, in the toes, due to the poor blood flow. It's relatively rare to have amputation because of cancer. Less than 2% of amputations are for cancer-related reasons. But for example, if you have a sarcoma, this affects the bone and the soft tissue in the bones. And if the cancer is too large or too aggressive to remove just the tumor, or if it's a recurring cancer, it might be better, and especially if it extends into the nerves or the blood vessels in your arm, it might be recommended for you to have an amputation of that limb to stop the cancer spreading and kind of permanently remove it. There's also severe infection can also be a major reason for amputation, particularly septicemia. You might know this as blood poisoning, which is basically really severe sepsis where drug-resistant bacteria spread in the bloodstream, and obviously this is really bad for you. It can cause disease such as meningitis, which is not fun at all. And to save people's life, to stop that happening, they might amputate the place where there's this infection, to stop it spreading again, similar to cancer. And although it's not technically an amputation in a surgical sense, there's also congenital amputation. So that's more to do with children being born without certain limbs, for example, without hands, feet, legs, or arms. And later on in life, these children might have some kind of surgery, or they might have artificial limbs, be given artificial limbs. So those are just some of the reasons that you might need to be amputated. Let's go on to Anupam, who's going to explain how exactly the amputation surgery works.
Amputation surgery has come a long way from the early days of surgery, where the surgeon would come along with the largest cutting tool he could find and ask the patient to just clench their jaw as they hacked away, often with little to no anesthesia available. Even after the discovery of chloroform, amputation surgery is one of the most traumatic types of surgery, often with the highest mortality rates due to shock, blood loss, and infection. Nowadays, the procedures used are far safer, and other than cases of emergency amputation, almost always it will be planned well in advance, with all alternatives explored. Nowadays, amputation is seen as only a last resort procedure. So unless you need to have an emergency amputation, you'll be fully assessed before surgery to identify the most suitable type of amputation and any factors that may affect your rehabilitation. The assessment is likely to include a thorough medical examination, which checks, among other things, your physical condition, your nutritional status, your bowel and bladder function, your cardiovascular system, and your respiratory system. The doctor also will check on the condition and function of your healthy limb. Removing one limb can place extra strain on the other, so it's important to look after the healthy limb. It may also include a psychological assessment to determine how well you'll cope with the emotional and psychological impact of amputation and whether you'll need additional support. Sometimes they'll even make an assessment of your home, work, and social environments to check if any changes will need to be made to help you cope. You'll often also be introduced to a physiotherapist who will be involved in post-operative care. A prosthetist, a specialist who's involved in prosthetic limbs, will advise you about the type and function of prosthetic limb or other devices available. Amputation surgery severs all the varied tissues of the limb. Each tissue must heal in its own particular manner, and a knowledgeable surgeon will consider each tissue's unique role as he plots a reconstructive course. And this careful calculation is essential to make sure that the most functional residual limb is left behind. There are very different levels of amputation, as amputation itself is a very extraordinarily broad term, covering the entire range of body part loss. It goes from the loss of a finger to an entire arm to chest wall level, and from the loss of a toe all the way to the entire leg or pelvic area. Even above pelvis, waist level amputation is often required. The term amputation is usually used to describe the removal of all or part of a limb, but technically it's more precise to reserve this term for the process of limb removal by dividing through a bone. And the term disarticulation is more precise for the process of removing a limb between joint surfaces. This is the difference, for example, between amputation that goes through your femur and amputation that goes between your hip joint. Upper and lower extremity issues are also very different, and deciding between limb salvage versus amputation requires different considerations for upper versus lower extremity injuries. The biggest consideration here is that the upper extremity is often not weight-bearing and can function with minimal sensation. And cases show that even if the salvage of an upper limb results in only minimally assistive function, this salvage is often better than the prosthetic substitutes available on the market today. In contrast, for the lower extremity, such as the legs, weight bearing is mandatory, and salvage often functions poorly if it does not provide enough protective sensation. In contrast to an upper limb, a salvaged lower limb must hold up to the demanding forces of walking and weight bearing. Some types of upper extremity amputation include partial hand amputations, where they remove parts of the hand, wrist disarticulations, where they remove the hand completely after separating it from the lower arm at the wrist, below the elbow amputations, where the lower arm is removed by cutting across the bones of the lower arm, which are the radius and the ulna. Elbow disarticulations, which are removing the lower arm after separating it at the elbow. Above the elbow amputation, where it's separated by cutting across the upper arm bone, or the humerus, and then shoulder disarticulation, which is removing the entire arm after separating it from the shoulder. In extreme cases, they also do 4/4 amputation, which removing the whole arm and also part of the shoulder, including the clavicle and the scapula. For the lower extremity, a similar distinction is made. You have partial foot amputations, ankle disarticulations, below the knee amputations, which cut through the tibia and fibula, knee disarticulations, which cut across the lower leg and the knee, at the knee, above the knee amputations, which cut across the femur, hip disarticulations, pelvic amputations, or pelvectomies, and double amputations, which are the removal of both hand, feet, arms, and legs. In extreme cases, they'll also have quadriplegic amputations, where all 4 limbs are removed. However, these are reserved for only the most extreme cases when needed. The procedure itself can be done under general anesthetic, where the patient is fully conscious, or using epidural or spinal anesthetic, which both numb the lower half of the body. This obviously depends on what parts of the body are being amputated. When amputating, the first part that is cut into and removed is the skin. The general principles of plastic and reconstructive surgery apply, especially in terms of incision location and placement of scars. While a planeless, pliable, and non-adherent scar is a primary goal in most surgeries, in amputation, the prosthetic interface and socket design can make the location of the eventual scar of increased importance, as that will be where the prosthetic and the residual limb have to interact. While uncomplicated healing can result in scars that are non-tender, pliable, mobile, and durable, this doesn't always happen, and scars could end up becoming adherent, tender, thin, and non-durable, and in this case, location will matter a great deal. Skin problems will often remain a major concern for amputees throughout their lives, and the amputation surgeon needs to be familiar with the many different types of short and long-term wound healing problems. Post-operative infections, wound dehiscence, and partial skin fat failure occur with unfortunate frequency in the short-term healing process, and complicated skin problems often require multiple care specialists to look after. However, once the skin is removed, the muscle is the next stage that needs to be dealt with. Muscles make up the bulk of the residual limb soft tissues, and an amputee with a muscular, well-padded and balanced residual limb is far less prone to chronic pain syndromes. Therefore, maximum retention of functioning muscles is essential to provide the residual limb with effective strength, size, shape, and circulation. Proper muscle function depends on the anatomic origin and insertion of the muscle, and without fixed resistance against which the muscle can forcefully contract, atrophy can develop. Therefore, to optimize efficient residual limb muscle activity, surgeons aim to stabilize the muscle under physiologic tension. Correct muscle tension varies from case to case, and the primary determinants of appropriate tension are somewhat hard to decide. There is no set of hard and fast rules. In general, most surgeons are on the side of too lax rather than too tight, as that will end up causing severe pain to the patient. However, one example of accidental implementation of excessive tension occurs if a surgeon advances the quadriceps under too far, a scenario that can lead to hip flexion contracture. Though it's difficult to establish a solid set of guidelines, stabilization is always an essential part of amputation surgery in the reconstructive process, as otherwise the muscles of the residual limb will end up causing extreme pain as they atrophy. Once the muscles have been cut away, the surgeon then proceeds to working on the nerves. The management of sectioned nerves remains a controversial aspect of amputation surgery. The free end of a divided nerve heals by forming a neuroma, and this intertwined mass of scar and nerve tissue can be painful to pressure, stretching, and other types of physical manipulation. Even when completely undisturbed, electrical potentials may arise within the mass, causing negative, local, and distant sensory and motor phenomena. And these sensations can be bothersome and painful to the amputee. While numerous techniques have been devised in order to minimize neuroma formulation, none have proven uniformly successful. These methods have included cauterizing of nerve ends using chemicals or heat, burying the nerve in a bone, encasing the nerve in impervious material, ligating the nerve, or injecting the nerve with a variety of chemicals. However, it's generally accepted neuroma formation is to some degree inevitable, and so the generally accepted management procedure is drawing the nerve away distally, sectioning it, and allowing it to retract away from areas of pressure, scarring, and pulsating vessels. Surgeons always take extra caution concerning the nerves, especially when it comes to the high-level upper extremity amputations. However, particularly in surgeries involving parts of the body such as the brachial plexus, nerves are often accidentally included in ligatures, and this leads to a lot of painful syndromes such as phantom limb. Once the surgeon has dealt with the nerves, they then move on to the blood vessels, the second to last part of the amputation process. Adequate hemostasis and the management of blood vessels and bleeding sites is of utmost importance in amputation surgery, and blood loss is still one of the leading ways people die during these procedures. Major arteries and veins are always isolated and ligated securely before the procedure carries on any further, and double ligation of large arteries is seen as standard, especially when the amputation is carried out in presence of only a normal blood supply. Cauterization is usually only reserved for small bleeding points, as they can't deal with large bleeding vessels or arteries, and amputation sites are usually drained surgically with suction drainage. A post-operative hematoma can often be a major complication that predisposes the patient to infection, and in worst-case scenarios, can lead in delayed wound healing or complete failure. Once the blood vessels have been securely tied off and resected, the surgeon then moves on to the final part, the bone. Often in amputation surgery, they'll use industrial-level equipment to cut through the bone, such as circular saws. However, they need to be very careful when dealing with bone, as cutting it at the wrong angle can cause it to shatter. The forces travelling between a prosthesis that is eventually fitted and the residual limb and the remaining body are in large part transmitted through this retained bone, and any weaknesses that are formed during the amputation process can lead to disaster for the patient later on. However, once the bone has been cut away, all that remains for the surgeon is to close the skin, and the standard protocols, as in any other surgery, are applied here. Dead space is eliminated, and drainage of systems is used when necessary. And when closing the wound, opposing tissue layers are sewn together under tension, and care is taken so that the final closure is neither too light nor too loose. If all goes well, the patient should not feel any pain whatsoever. However, it is one of the most common post-operative symptoms. However, this is not like a normal surgical procedure, and as such, this amputation has a lot of post-operative care that will need to be done. The general principles of primary amputation also apply to revision amputation. Revision is necessary for the following reasons: when the primary amputation fails to heal, or the residual limb is unsatisfactory for fitting prosthetics. It's also a viable option for pain issues, but only when the patient's pain is clearly identified for a cause. These can be things such as bone spurs, painful scars, and distinct and identifiable neuromas. Surgery specifically for the treatment of phantom pain has not been successful, as it is not clear where this always comes from. The residual limb is usually covered in either a soft or rigid dressing, and there are many advantages to each one, but also their respective cons. Soft dressings have long been recognized as essential for controlling swelling, and while an unquestionable benefit to the healing process, elastic bandages need frequent changing and require close monitoring to maintain the correct amount of pressure. When used exclusively, soft dressings can frequently make muscle conditioning and pain control more difficult, and many surgeons can consider simple soft dressings outdated, even though in many other places they're the preferred method. Rigid dressings, on the other hand, have been the go-to method for treating both open and closed amputations since the First World War. The primary objection to the rigid dressing as a post-surgical form is that the dressing itself prohibits frequent inspection of the operative site. However, the frequent inspection of the operative site, prevention of that can often be advantageous, as it leaves the wound to heal on its own. These trade-offs have to be carefully considered, and a whole team of doctors will be supporting the patient through their post-operative rehabilitation to make sure that the wound heals properly. In most cases, the patient will be also offered the chance to have a prosthesis fitted, and for more information on how prosthetics work, I'm going to hand over to Adrian.
Prosthetics help people by serving as a replacement for a specific body part that has been amputated. Over the years, prosthetics have become more advanced and sophisticated as technology improves. The type of prosthetic someone needs will vary based on several determining factors. Well-designed prosthetics offer much-needed functionality, provide emotional comfort, and help the amputee regain their sense of wholeness. There are 4 main types of prosthetics. These are known as transradial, transhumeral, transtibial, and transfemoral prosthetics. Each prosthetic serves a different function, depending on what body part was amputated. A transradial prosthetic fits on the arm below the elbow. It encompasses both the forearm and a wrist. Newer models of this prosthetic have wires and cables. The transradial prosthetic gives the amputee a robot-like arm, allowing them to perform several arm functions with relative ease. Transhumeral prosthetics sit on the arm above the elbow. It's one of the hardest prosthetics to get fitted because of its position above the elbow and the need to encompass this joint. It's also a complex prosthetic functionally to get it to mimic someone's natural movements. The most common attachment method of connection with a transhumeral prosthetic is to use a suction system. A roll-on linear system is also another way to affix the prosthetic limb. The next type of prosthetic that I'll be talking about is the transtibial prosthetic. This prosthetic attaches to the leg below the knee. People who need a transtibial prosthetic still have a healthy part of their leg, which helps with mobility. Many amputees with transtibial prosthetics can partake in various recreational sporting activities because retaining the knee makes normal movement easier. One important thing to remember with this type of prosthetic is that the person's entire weight rests on it. It's crucial to find one that fits the patient comfortably and can take the patient's weight throughout their daily activities. As such, the transtibial prosthetic may differ based on what the person does. It may be different for a person who works in an office compared to a person who is a regular athlete. Finally, we talk about the transfemoral prosthetic, and this prosthetic sits above the knee. Because the residual limb is shorter than the transfemoral prosthetic, the amputee takes longer to rehabilitate and may have a more challenging time regaining normal movement. Transfemoral amputees must use around 80% more energy to walk, compared to someone who hasn't been amputated. Newer technology, such as inclusion of hydraulic pumps and direct bone attachment, are helping amputees recover sooner and faster. Body-powered prosthetics are widely used, but electronic versions are becoming increasingly popular. Technological advances have been made electronic prosthetics easier to use, and they more closely mimic natural body movements. With electronic arm prostheses, electrical signals are transmitted from the person's brain to their arm muscles, which tells the device how to move. Currently, most electric hands can handle basic open and close movements, whilst ones with individual finger movements are being developed. Leg prosthetics typically rely on a single motor that controls knee movement through electrodes implanted in the thigh. There are some advantages and disadvantages to electronic prosthetics. One of the biggest advantages is that these prostheses require less muscle strength to operate. They also tend to be comfortable and look more realistic, especially those covered by a latex skin. One of the biggest cons to these prosthetics is cost. They are significantly more pricey than the prosthetics you control manually, and you will need to make sure to charge the batteries every day, and they need regular maintenance. In the event of a battery failure, you cannot use the device. And you cannot use these around water because there's a risk of damaging the battery. Electronic prosthetics also weigh significantly more than body-powered limbs. Finally, we talk about disadvantages of prosthetics as a whole. Prosthetics are, by no means, a complete substitute for the natural limb. There's no way that currently we can develop an artificial limb that works just as well as the original limb did. And indeed, they are a way of providing a better solution in cases where the limb has to be amputated. Hopefully, in the future, prosthetics can be made lighter, more portable, and more durable, so that the patient may one day reach a point where they do not feel the prosthetic at all. So now that I've talked a bit about the types of prosthetics and their advantages and disadvantages, I'll hand back to Shrey to wrap up today's episode.
So, I hope you've learned a lot about amputation and prosthetics, and you have a greater appreciation for what some of these Paralympic athletes and general amputees have to go through on a daily basis. Thank you for listening to the Medisodes podcast, and we'll see you next week for the next episode.